Well, let's go ahead and get started. We're looking to potentially have more of our Insight classes be done in a Zoom format as opposed to a pre-recorded video format. And so we were just talking about this, and then I got an email from our speaker today who said, "Hey, I'd like to do this with Zoom." And it's like perfect timing. So hopefully we won't have any logistical or technical difficulties. But I would remind people to mute their microphones when they're not speaking. And also want to let you know that we'll be recording this and hopefully, if all goes well, putting it on our YouTube channel later today. We're in the midst on the Insight classes of a series on well-being, and our speaker today is a perfect person to talk about this topic. Dr. Mary Kenen has spoken with us before at Insight class. She is an anesthesiology specialist with more than 36 years of experience in the medical field. She graduated from the University of Minnesota Medical School in 1984. And she was just telling me, did a fellowship and took a job here in Cedar Rapids. The title of her talk is Medical Privacy, A Brave New World. So I'd like to welcome you, Mary, to the Insight class.
Thank you. Well, some of this you may already know, but I thought it might be useful just to go through the Can you hear me now?
Yes, I'm sorry, Mary, that was my mistake. I was muting myself and I muted you by accident.
Okay, no worries. I just thought we would talk about the process of medical information security first, and then talk about some scenarios. So the first question is, why does a medical facility ask for your social security number? Well, in some respects, it is required. So any government provided health insurance requires your social security number. So that includes Medicare, Medicaid, VA hospitals, all of those types of entities rely on that. They require it. It does, as you can imagine, provide identification across several different medical entities. So if all the facilities ask for it, then it allows them to use that, although in all honesty, most entities use your name and date of birth. We don't really toss around your social security number to track you through different healthcare facilities. Of course, you've heard me too many times talk about the fact that our healthcare system is finance driven, it's a business, and this is the ultimate way to track people who don't pay bills. The American Hospital Association says over $40 billion in unpaid bills rack up every year. So that's another way to track that and try to get payment. Well, you might wonder, do I have to give my social security number? And actually you don't. So when you are asked, if you check in at a clinic or any other facility, you can say, or you can ask, do you absolutely have to have it? I don't wish to give my social security number. Now, again, if you have Medicare, you have to give it. If you have Medicaid, you have to give it. But you always have the right of refusal if you don't have government-based insurance. However, they also have the right of refusal to say, we won't treat you if you don't give us your social security number. Well, let's look at the medical advantages of using that number. Obviously, in theory, you have a unique social security number given to you at birth. And so that would imply that the information that passes around with that number relates only to you and gives us a certain sort of accuracy. In theory, it allows us to accurately notify next of kin for the same reason. We know that it's you. It, in theory, also prevents the mishandling of confidential records, and we'll get into that a little bit later, and prevention of inaccurate billing notification. But again, obviously, there are issues with that we all recognize. Well, you all know this term, this acronym HIPAA, HIPAA stands for the Health Insurance Portability and Accountability Act. So when it was first passed, part of the idea was literally to increase the access across medical entities. So 20 years ago, when I practiced at St. Luke's, it would be such that if you weren't in the St. Luke's system on a piece of paper, I really had no information about you unless someone had faxed data from another facility and copied it into your paper record. But if you were a patient at Mercy and I was standing at St. Luke's at 7 o'clock in the morning, I had no way to access that information. And so the government recognized that records needed to be more portable, if you will, and more accessible across different entities. So that was one point of that. According to HHS, in 2019, there were 500 large, mind you, large data breaches, which was a 196% increase over 2018. So when we speak of accountability, we all recognize that computer systems are wonderful for giving portability and giving access to information, but there's a real accountability issue because there is such open access, and of course we all know that access is breached. So we've invited the portability factor in, which to me as an anesthesiologist is just invaluable, but we've also created a huge problem with the accountability because of the access through computer systems. I'm sure you all realize when you first step up to a desk in any medical setting now, you're asked to sign a notice of privacy practices. And I wanted everyone to realize when you sign that HIPAA release, it allows what we call routine disclosure of records. So meaning access that people who should legally have access do get it, but you need to realize it is without further consent. So you really are consenting to allow data to be used across a multitude of medical settings without you signing another piece of paper. And that's very, very different from, again, 20, 25 years ago. In the past, if I wanted to get the result of a radiologic study that had been done at another hospital, or in particular cardiology records we always want in anesthesia settings, I couldn't get it unless I could find you, the patient, and have you sign a piece of paper and send it to the other facility, and then have the records faxed over. And that was a very cumbersome process that didn't work very well at 6:45 in the morning. So who has access to your medical records? Well, you all need to realize that your first point of access is you. You actually own all of your records. And if anyone tells you that you can't have a copy of your medical records, you need to realize that legally you are the owner of those records, not the facility. They are caretakers of your records, but they actually belong to the patient. Your family or your caregiver can have access, but only with your written consent. So for my elderly parents before they died, and for a brother who was severely ill before he died, I was the medical consultant, if you will, the medical decision maker, but I had to have them sign consent for me to have that access. Who else has access to your records? Well, as we've implied, any medical provider, facility like a hospital, anyone who has to deal with your health care, laboratories have access to your records, billing entities. I have a billing service, and they, by law, by decree, in order to do their billing for Medicare, for private insurance companies, have to be able to review every anesthetic that I do. So that means they have access to every anesthetic in order to review it for time compliance and that type of thing. Health and Human Services, the government agency that oversees healthcare, has access to your records in order to track fraud and compliance. State law allows many entities to have access specifically for tracking public health issues. And of course, number one on the list that we all recognize now is a communicable disease. So in the times of coronavirus, the states want to be able to track patients and track what has happened with people in order to analyze those statistics. And so they do have access to your diagnostics to know if you were diagnosed with something like coronavirus. Obviously, they use this information to track child abuse cases, violent injuries, and the one that everyone knows about through television probably is the idea that a psychiatrist may be responsible for relaying information to the police if a patient has expressed the desire to harm someone. So people you might not readily think of who have access to your records are technology providers. Sometimes when I'm in the middle of an anesthetic, the computer acts up and I literally can't record data or I can't access data. So I have to call IT and they have to link in order to get into a record. So when you think about that, these young people, they're mostly young, who are hired to do IT for medical entities, are really carrying an enormous burden of responsibility to not abuse that power to access records. They are much more clever at getting into medical records and fixing issues with computer systems than I will ever be, and that's an enormous power to have. So anybody who hires someone to do that needs to make sure that they are extremely responsible with that enormous power. Law enforcement obviously can have access if it's necessary to solve a crime. The interesting example I found looking into this on the web was that the FBI may get into your medical records if you've been accused of an international terrorism incident. So beware, if you're trying to conduct an international terrorism ring, your medical records may end up with the FBI. Well, as I'm sure you realize, every year over 2 million people, and that seems like a very low figure to me, are victims of medical identity theft due to hackers, those nebulous people that we hear about all the time who seem way too clever at getting into computer systems. Targeted theft for business or personal use. This is actually even legally used in medical settings. So companies will try to query records to look for patients who have specific diagnoses or specific health issues in order to target them for advertising about certain types of medications or medical devices. And perhaps the most scary is the accidental identity theft when, say, an office upgrades its equipment and they don't properly scrub or erase the computer system that they get rid of. So now personal data is out on a piece of equipment and can be easily stolen. Well, you would think the Social Security number is both good and bad because, again, it relates to each of us very uniquely, but it was never intended as a universal personal medical ID. It was intended for a completely different purpose. And of course, as we all know, it's been widely abused and it's used in so many settings now that it's hard to keep your own social security number confidential. And to me, the last 4 digits has simply become the full social security number in a sense. It's so widely used now, I can't imagine that it doesn't provide another easy access in some way. So under the HIPAA law, they did try to create a unique patient ID, so something that would be created for each of us, but Congress blocked that, unfortunately. Those of you who have Medicare, and certainly those who have had Medicare for a number of years, remember the crossover from when your Medicare card actually had your social security number on it. I remember my mother's. And of course, that was terribly insecure because if you lost that card, if you had someone make a copy of it, your number was automatically now distributed widely. In the new era, Medicare assigns an ID to each participant, so more like a unique patient ID number. And in theory, that helps protect a little better. Well, the ultimate question this morning regarding this part of the talk is, how do you protect yourself? Well, as I've implied before, you should ask if someone asking for your social security number actually has to have it. Do they absolutely need it for treatment? And if they allow you to not give it, you shouldn't give it. Because anytime a system is breached, someone can get a hold of your social security number, and it may be tied to other data about you, which leads to the second suggestion, that is, pay with co-pays with cash. The reason being, again, if the system is breached and your social security number, your address, your name, date of birth is tied to a credit card number, now they have all the data they need to do quite a bit of harm to you in terms of your finances, your security across the board. So if you pay with cash, yes, they could still breach the system, and if you gave it, get your social security number, but they may not get much more information about you that can be used to dig into your finances. The third point here, I'm sure I don't need to stress at all. I would hope that everyone carefully scrutinizes medical bills. It's always like some sort of a bizarre lottery when you get the bills. You have no idea what the numbers will be, what exactly they relate to, how many more you're going to get. It's something that I criticized previously in our system, because it's really very hard on patients, and it's just really difficult to ever assess whether you have been charged fairly or not. But in order to protect yourself, make sure you look at the name and the date of birth and any other identifying information on bills, because mistakes can be made. Obviously, you would want to contact the entity that sent you a bill if you receive something intended for another person. And I'm sure for all of you that goes without saying. Well, I thought we would go through some scenarios because I wanted people to understand we obviously have very broad access, thanks to HIPAA, in looking at your medical records, but there are medical reasons that are safe for you, that bring safety to you in medical settings due to that incredible access. So I just put together some scenarios. Some are actual cases and some are simply made up. So let's say that we have a patient brought to the emergency department who is unresponsive and with no family present. Well, we wish to have their identity and some sort of access to records revealed for two reasons. One, we obviously wish to notify family that this person is there and they're in serious condition. But the second reason, again, to me as an anesthesiologist, but to all physicians, is we want to be able to access any records that exist in order to have more information about this person that may be necessary. If the person has to go emergently to surgery, there is one condition in anesthesia in particular that involves a life-threatening reaction to a standard anesthetic. It's a condition that runs in families, and we want to know if that person has it, because we will give a different type of anesthetic if we know that they do. So there are real distinct medical reasons to know some history, and if we have access to records through identification, we will access them. Well, let's add a complication to that scenario. So now the person is unresponsive, there's no family present, but there is no identifying factor on the person. This was an actual legal case presented, and what the hospital did was put information about this person out to the media because they felt they had no choice. They had absolutely no idea who the person was. They knew nothing about their health history. They had no way to contact family. So that's kind of a unique situation in which the normal process of obscuring a person's identity in a medical setting had to be breached because they really needed to be able to contact someone and connect that patient with a family, with records, all of that. Well, in today's society, we have so many blended families and so many unusual.
Harry, could I ask a question about that? What happened in that court case?
It was deemed correct that the hospital had a right to submit it to the media in order to try to find family. So they felt that the hospital was within their legal right to do that. Yeah, good question. So we have a lot of blended families. We have a lot of adults living in facilities, not with family members. We have children living in foster care. So from a legal standpoint, we always have to be very careful that we contact the person who legally has a right to sign for a child. But think of a scenario where a parent, someone who says, I'm their parent, comes in and asks for immediate release of records. Well, of course, if you have a legal parental care designation, you do have the right to have immediate release of any records from a doctor's office. But we have to all be very careful that the person accompanying a child or someone who cannot speak for themselves really is that person who has the right. And so that's where we are very, very careful to designate who can have access to those records. Now, the irony for me as an anesthesiologist is not so much from the standpoint of releasing records, but in discussing a patient's health history or records. I will have oftentimes an adult who lives in a facility, so a family member who is the legal guardian will have signed a consent, and we will consent by phone ahead of time. But actually the person accompanying that patient and giving me the most detailed medical information is a caregiver in their facility, because they know them on a day-to-day basis, and they know what they eat, what they take medically, they know how they respond to things. And the relative who gave the consent may actually have much less idea of that patient's actual medical situation. So again, it's a different world, a brave new world that we really didn't encounter as much in the past. Well, as you can imagine, these days we have many patients who have high-risk medical issues. They need specialized care. Again, as an anesthesiologist, I need to read the records of lung specialists, heart specialists, kidney specialists, diabetic managers. I actually work out of the anesthesia pre-op clinic 1 or 2 days a week. And so in that clinic, we are literally trying to pull together the overall picture of complicated patients in order to better decide, can they have surgery? Can they undergo an anesthetic? How do we do it? And so in order to do that, we have to have access to all of those different records. And I do have to say that computer systems and HIPAA have really facilitated that ability to look at complex issues. So one thing patients should realize is, even though you've never met me, I may have seen a lot of your records, and I do that in a confidential nature, and I do that in order to better provide for safety when you come into the hospital and have a procedure done. Likewise, it is recognized in legal settings that we have a right to do what we call a curbside consult, meaning I can stop another doctor that I happen to see and, as we say, run a case by that person, saying, I have a patient with this complicated problem, and this is what I am thinking is reasonable. Do you agree? It's not to say that we do these things lightly, but sometimes it is helpful to ask another's opinion. And we are intending to do that confidentially. We don't identify you, but we're simply trying to get more background and get a better sense of how to deal with something complex. Obviously, if we need to, we make a formal consult and even send a patient to that specialist. But there is exchange of information between medical entities, nurses and doctors, doctors and doctors, about issues without having to reveal personal data, but revealing medical information to get an opinion. Now, let's change that and say it's a high-risk disease requiring specialized care, but it's going to be discussed at a medical conference. Well, again, this is an opportunity to talk about somebody anonymously, but gather the opinions of a lot of experts. So I've been to many different types of conferences, cardiology conferences, anesthesia specialty conferences, and we do talk about specific cases. The understanding is we will always do that anonymously. If there's an x-ray shown or a cardiac study shown, the name will be obliterated, and we may very well look at your heart beating on a screen, but we will not know it's yours. And the presenter is expected to not identify any information about the patient that will be obvious to anyone in the audience. The way in which we have to be very careful is cases that have a very high profile, cases that have a national media presence or something like that. We have to always make sure that we're presenting something in a way that no one in the audience could identify the patient unless the patient wishes to be identified. And I have seen that in conferences where a patient is actually interviewed on a screen or actually brought up on the stage. And that in that situation, they will have consented, they will have agreed to have themselves disclosed and identified in a conference or on a media setting, let's say. Well, the last scenario I wanted to present was what I alluded to before. If a patient has a family member with a high-risk genetically inherited disease requiring specialized care. So this is something that I see rarely, but I have seen it several times over the years in, again, my anesthesia clinic setting. A patient comes in who needs an anesthetic, and they say that a family member has this disease, perhaps. There's a way to identify the disease now through blood testing or a muscle test, but not every family pursues that. And so a family member may have had the reaction typical of the disease, but they were never tested. So I, of course, interviewing this person, knowing they have a close relative who had the reaction, want to know were they specifically diagnosed or not, but I cannot access the records of that family member without getting specific consent with a family member. I can tell you probably 2 or 3 times over the years, I have actually gotten consent from the other family member to dive into their records. But anymore, the way that we handle this is we deliver the other type of anesthetic that won't result in the reaction, and we leave that question unanswered. But we always tell the patient who doesn't know for sure whether this family history is truly the disease or not, we tell this patient, the current patient, that they really should pursue it and they should be tested for it if their relative wasn't. So what I hope you realize from what I said today is, yes, we do have broad access to people's records. And again, I stress, I may have reviewed records on countless people in this area who have never met me, don't know anything about me, and can't imagine that I've looked at their records, but I do it confidentially, and I do it in order to try to provide safety to them in anesthesia settings. And you nonetheless should be very, very careful about who you give qualifying information to. So always ask if you have to give your social security number, and be very, very careful with any identifying information. And that is all I have to say.
Thank you, Mary.
You're welcome.
If you unshare your screen, I think we might be able to see people who are attending the class live. Are there questions for Mary?
I have a question, Matt. For those of us, I think probably most of the people watching this, who are old enough that we had both the old Medicare card with our social security number and the new Medicare card with a completely different number. When Medicare issued those new cards and new numbers, did they break the link with the social security number, or is that still on file somewhere with Medicare, and a person who's adept at computers could take the new number and from that get the old social security number?
That's an excellent question. I actually just got my Medicare card. So, you know, in November, I will be joining all of you who are on Medicare. I can't imagine that they aren't linked. I assume that they are because you submit your Social Security number when you apply for Medicare. So I'm sure at the mothership, those two are linked. And that's what we all worry about in terms of anybody hacking into government systems, any type of medical entity. I would say hopefully most offices and hospitals are very careful about how they protect the Social Security number from that Medicare number. But again, I don't know enough about how hospitals design their computer systems to tell you that. Yeah, I wish I could say you don't need to worry, but I can't.
Mary, it seems like with the advances in computing technology, sharing of information is so much easier than it used to be. And I guess HIPAA is partly to counteract that and provide some level of privacy. I wonder if you compare medical privacy today versus, say, 50 years ago, 40 years ago, do we have more privacy or less privacy overall?
Well, I would actually say it's a mix, and it's funny that you say that because the sort of humorous way I can discuss this is back in the day, your chart would be on a revolving carousel at the nurse's station, and anybody walking by could see the names of patients. And I will tell you that more than one person would stop and say, oh my gosh, so-and-so is in the hospital. They could walk over, flip open the chart and look at patient's chart. Nowadays, what hospitals do is they give you a time limit. If you are in someone's chart, they start timing how long you are in that chart, and they will literally come after us for inappropriately being in a patient chart that we should not be in. So they actually keep an eye on that. I don't know exactly how long the time limit is, but it's something under a minute, I understand. So, you know, we all accidentally get into the wrong chart occasionally. We have a name and we've looked at it and, oh, we chose the wrong date of birth. We're in somebody else's chart. The hospital allows for that, but they will not allow you to simply graze charts of neighbors or anyone else. And so that's one way in which you are actually sort of protected by computer systems. But of course, the way that we are all unprotected is having maybe an unscrupulous employee in a facility who is on the side selling data, or again, having a computer system that wasn't completely erased before someone discontinued use of it. Unfortunately, computers invite so much ability to access information inappropriately. And I think that's something that we will continue to struggle with. And it's the ultimate question going forward. The other obvious issue is when a computer system goes down, which it does sometimes at the hospital, then we are all left with no information. And we're back to dealing with putting results and data on paper, but having no access to anyone's information. So.
Great, thank you.
I have a couple questions.
Yes.
I have two questions. One, I read a book a long time ago in the Mayo Clinic, and one of the things that impressed me was their, I guess, willingness to collaborate with fellow doctors to get the best outcome. And your experience, how do you see that happening around here? Is there really a heartfelt willingness to get the best answer? And have you heard of that rating group called Leapfrog? I think it's a nationwide group that kind of evaluates hospitals. And are you familiar with that? And I'm wondering why I don't think St. Luke's or Mercy does that. So that's all.
Okay, well, I'll answer the last one first. I'm not familiar with Leapfrog. All I can tell you is there are many, many evaluating entities in healthcare, and I certainly can't keep up with all of them. I can tell you this, having worked in Cedar Rapids and now worked in other hospitals. I worked in New York in May and I worked in Georgia in August to help with coronavirus patients. So it gave me a very close look at two other hospital systems. And obviously my residency training was in Chicago. So I've really seen different systems in detail over the years. I think healthcare is extremely well done in Cedar Rapids. And I can say that I find more and more physicians really do want to connect with one another and try to share information and opinions. And we really do try to design care, custom design care for patients. So I feel very good about that. And I don't say that because I practice here. It's really just something that I've observed over the years. And again, with exposure to several other healthcare systems. So I think part of what helps us is we're kind of an island, and we have been very fortunate to hire very capable physicians over the years across the specialties. And I think because of the lifestyle here, it keeps people here who tend to have a very compassionate and humane approach to what they do. So we don't see some of the excesses that I saw during my residency training in Chicago, for instance. And I think that you actually are very well served in Cedar Rapids, and having access to data helps immensely in that.
What were the excesses during your residency training you're talking about?
Well, people who were on hospital staff, not so much at the University of Chicago, although there was some of it there, but in the outlying hospitals in Chicago, people that probably should not have been board certified or maybe weren't board certified. So an example I can think of always is at one of the hospitals we had to rotate through, there was a doctor who gave extraordinary doses of insulin if somebody had a high glucose level, such that he would put them into a coma from hypoglycemia. And that was just his standard treatment to counteract a high glucose level. He did things that were extremely inappropriate. And, you know, you tend to see things of that sort sometimes in systems where the patients are very random to physicians. They don't have a communal sense of dealing with people who are their neighbors, their friends. And that's part of what I think helps a healthcare system like Cedar Rapids. We have been very fortunate in recruiting, and everyone here feels a real moral responsibility to patients. And you just don't see that, I think, a lot of times in large cities. Patients become random entities to all aspects of the healthcare system. I also did time in New York when I was in training, and it was similar there. It was an inner city hospital, and just the comments that are made sometimes by healthcare personnel or the way that people are treated tells you they really don't have a vested interest in patients. And I don't see that here in Cedar Rapids.
I have one more example for you of that, especially the cooperation among physicians here in town. You were part of a panel in May about treatment for COVID-19 here in Cedar Rapids. And we had physicians from both hospitals and PCI independents all participating in the panel discussion so that they could talk about what they were attempting to throw at COVID-19 and what worked and what didn't. I think it was very much appreciated by the physicians here in town. And there was great cooperation and obvious interest in what everybody else was learning about that whole process.
Yes,
so thank you again for being part of it. But it was really
thanks. I think we have some really good medical leadership, and we do have people who are very interested in keeping the lines of communication open. It's not quite the same as it was when I first arrived here, but I can still say that when I need to consult somebody, or yes, these meetings that we have to try to educate anyone who wishes to tap into it, all bring a sense of quality and keep the lines of communication open in Cedar Rapids. It's very important.
We hear increasingly about ransomware being directed at healthcare facilities, especially large hospital chains. What precautions do large healthcare facility chains take to to defeat ransomware attacks? And are these in reality effective, or is it just a matter of time before Unity Point, for example, falls victim to this?
Well, you're getting outside my area of expertise. I wish I could tell you, but that's probably another whole hour discussion by someone more engaged on the IT side. I can tell you the hospital is constantly very aware of this issue, and regularly in our corporate emails, we get reminders. Actually, they do phishing expeditions, some of which I have fallen into. Yes, they're trying to send bogus emails in order to teach us what to not respond to, what to not open up. So they're really constantly vigilant about it. But what you just said and what you asked is really the ultimate question. How can you prevent a Unity Point from being one of those entities held hostage for money by some attack? And I don't know the answer to that. I think it's something that we as a society need to really ask our legislators and our governmental officials about. How are we going to protect what is now this very nice, large, interconnected healthcare system from becoming just an access highway to thieves who would steal all types of personal data? I really don't know the answer.
I don't know of any hospital that was attacked, but I know of at least one independent practice here in town that was attacked with ransomware, and all of their records were locked up and unavailable to them. They had their own IT person delve into it and fix the problem rather than coming up with the ransom. But it certainly disrupted at least one day of practice for the facility.
I thought
Yes.
Unity Point about 3 years ago got ransomware.
Oh, did they?
Well, I know more than one big hospital in Iowa has, and the reason I know is my husband's a radiologist. He goes out to all of these other hospital systems. And so at least two of them, I'm trying to remember where, north of us, actual large hospitals were held for ransom. So it's out there, and it just takes someone clever enough to figure out how to do it. But I wish I knew the answer for you. I don't.
I have another question, but does anybody else have any other questions first?
Well, I have a question about the Congress not acting on the patient ID issue. I'm just wondering, is that because there were concerns about establishing unique patient IDs, or is there some other reason why that never happened?
I actually don't know the answer to that. I would wonder if it's the same reason we don't have some type of universal health care, that we just don't, we have so much animosity towards any universal system in the US. But that's a good question. I didn't really pursue the reason for that. Yeah, I don't know.
Thank you.
Well, and go ahead. Go ahead, Tom.
Just said thank you.
Well, I've been following the COVID-19 situation with the Gazette and the internet. And when you read the articles in the Gazette, there are several examples over the last few months where the reporters seem to indicate the government's trying to hide data, and then they use the HIPAA law as an excuse. Well, we can't do that because of patient confidentiality, which is a total BS.
That's totally incorrect. The state has the responsibility, really, not just the right, but the responsibility to track all of that data. I think Iowa has been very duplicitous in how it has accumulated data, how it has analyzed data, certainly how it has released it to the public. I've written more than one entity in our state about that because it's not the way it is supposed to work. HIPAA protects the patient, but as I mentioned before, as long as we erase personal data, we really should be submitting data for all types of analysis. That's one of the benefits that countries that have universal health systems have over us. They have automatic access to a huge array of data on every patient, every person who is treated in their system. And we, of course, have this totally scattered system. I think it's one reason that COVID did so easily march through the United States. People were afraid to go to the doctor because they had no health coverage, or they had no legal status here. We have Medicare patients who are all registered and carefully monitored, but we have private insurance patients who may or may not be monitored in the same way in our system. We have Medicaid, we have uninsured patients. So we really have no overall way of tapping into the healthcare results of all these people. And it really means that we're very ill-informed about the march of any disease entity through our country, whether it be heart disease, diabetes, or coronavirus. So I agree with you. The state has been just terrible at accumulating the data, analyzing it, and then certainly releasing it to all of us.
Yeah, we have not been terribly impressed with the physician in charge of the public health for Iowa. And our son-in-law is working, he's the president of the Iowa Medical Society this year. And he's been approached by several members saying, what can we do about this person? And how do we, do something? And he says, well, that's something any physician who feels that she is not treating this data right, or, she's doing some sort of malpractice, can bring that issue up with the Board of Medicine. Iowa Medical Society doesn't do that. Iowa Medical Society is in a different position, and he can't advocate one side or the other. He kind of has to walk this thin line between the different parties. But interesting that so many physicians have said, we're not getting any useful information out of her.
Well, and she
compared her
misinforms.
to the Charlie Brown teacher, the wah, 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 wah teacher.
Yeah, she actually misinforms, and she makes misstatements, and I find that very, very dangerous in the middle of a pandemic. So I agree with you. I now know I can contact the board. That's a good thing to know.
Another thing Brian has had to deal with is the comments from Joni Ernst about
Yes.
being skeptical that the data being presented by physicians is actually not correct and might be used to inflate their income in some way, ignoring the fact that many doctors' offices were completely closed down and their income was totally shut off for several months this year. It just infuriated him to hear that so-called skepticism from Joni Ernst, and he had a Zoom meeting, phone call, whatever, with her about it. Yes. I don't know that it got anywhere, but IMS and Joni Ernst office were to put together a joint statement that was going to walk back her previous comments, hopefully. And I don't know that they ever came to an agreement together. IMS finally put something out on their own, but it was very hard to get the cooperation they wanted.
Yes, I agree. I was alarmed at her statements. I actually had a letter published in the New York Times about that because that wouldn't publish my letter here, but
we saw it on Facebook.
Yeah, that's what I heard. Somebody put on, I'm not on Facebook, but I heard it was out there. But I did call the Medical Society to thank them for correcting that misinformation and for saying Iowa physicians did not view coronavirus as a financial windfall. We viewed it as I said in my letter, a humanitarian disaster. Right. And it was extremely irresponsible of a senator to make that comment and to base it on data that I understand is, one of those misinformation sites. It was completely manufactured information that she was forwarding to everyone in Iowa. And I agree that it's the duty of the IMS and it's the duty of all of us physicians to speak up in that situation and to make it very clear we try to do what's right. And that's, again, what we were talking about. In Cedar Rapids, physicians are mostly very, very responsible people who care deeply about patients. And you know, the patients come first. The finances are always secondary. And of course, as you noted, many of us had huge financial hits in this because of the disruption to our practices. So I was very glad that Brian did have that phone call, and that IMS subsequently released another bit to say, we are here for the patients, not for the money.
So I don't know if I don't know if I hit, you can't see me, but why, when they publish a letter, because they publish letters all the time critical of, you know, politicians.
Yeah, I don't know. I've found that some of my letters recently, they haven't been as willing to publish, but there was one that was actually quite similar to mine that they published about 2 weeks later. So, you know, I imagine sometimes it's just that they want to allow people to have different voices, which I think is important. And maybe they had more than one letter that stated the same thing. And I do see now there is the ad, which I like very much. I don't know that physician who's in the ads. It's a doctor speaking personally, saying exactly the same thing. We did not treat patients to earn money. We treated patients to take care of people and save lives.
I think she's
yeah.
an interesting point.
Oh, is she? Okay. Yeah, I was glad that, I think the ad is very good. It simply states what we all feel. So
Thank you.
I think we're going to have to cut it off because some of us have to get off to virtual church. So thank you very much for joining us. And next week, we're going to have David Hayes talking about things on the general topic of well-being. I believe his may be just a YouTube video as opposed to a Zoom meeting, but I think we're going to be doing more and more of these Zoom meetings as we go forward. So thank you again, Dr. Kenen, and we look forward to having you back in at some future time.
well, thank you all. This is always fun to do. So thanks for inviting me.
Thank you.
Thanks.
Good to see you
Take
again.
care.
Bye all.